Hi. Today, the topic of discussion is automated hemogram. So, what is the use of this automated hemogram? You all know that during our physiology session in second year MBBS, you might have known or you might have used something called what is this? This is called newborn chamber. And in newborn chamber, you utilize these spaces for WBCs, and you use the central area for platelet as well as CBC. But this newborn chamber seems to be very time consuming, and you need to have a proper expert person to find out what is the real WBC, RBC, or something. And it is not a point of care test. It doesn't mean that when you want a CBC, when you want an absolute neutrophil count, basophil count, or a hemoglobin, it doesn't mean that with the help of a newborn chamber you will immediately get the result. It is highly impossible with a newborn chamber. And remember, there is an inter-observer variation. What do you mean by inter-observer variation? Because you can have a person A who will be giving some other neutrophil count, a person B, a technician, another technician will be given another neutrophil count. So it is cumbersome, time consuming. It takes such a long time to interpret. It will not be available as early as possible, and you cannot treat the child immediately based on the CBC result. Even though it is a gold standard test, we are not using newborn chamber nowadays. We are not using newborn chamber nowadays because this newborn chamber has been replaced by something called automated hemogram. What is this automated hemogram, otherwise known as Coulter counter? Because the person who invented is Coulter. So this is called Coulter counter. And remember and believe me, you need just a drop of blood. I repeat, you just need a drop of blood in this Coulter counter. Keep a drop of blood. It will give you the immediate results, and even 100 samples, 200 samples can be processed at a single point of time. So what does it mean? You will get your result as early as possible. So based on which you can tailor made your treatment, because if you have a neutrophilia, it can be a leukemia reaction, you can start an antibiotic. You can see a number of neutrophils with the bands. It means so many immature cells are released from the bone marrow. So what does it mean? You can plan your management as early as possible when the child comes or when the patient comes. So this makes things easier, and it will be given in a printed format. Look at this printed format like this. So it will be available as a printed format. So when it is available as a printed format, you can analyze your neutrophil count. There are only three cell lines now: WBC, RBC, platelets, and with these and there are so many sub parameters, and you can get your diagnosis as early as possible, and you can plan your management early. Right, what is the basic principle behind this Coulter counter? Very simple. The basic principle behind the Coulter counter is, look at this. The apparatus mainly finds out the size of the RBC suspended in the plasma. So based on the size of the particles, whether it is RBC, WBC, or platelet, it will match. See, look here. If the size of that particular particle that goes through the particular pore, and if the size is between 2 to 25 femtoliters, the Coulter counter reads it as platelet. So whenever any particle size is between 2 to 20 femtoliter, it is always platelet unless otherwise proved for the Coulter counter. It will not identify what it is. When some particle which crosses the pore and it is 20 femtoliter, it is platelet unless otherwise proved. One. And if the size of the particle is somewhere between 25 to 250 femtoliter, or else I can say an average of 100 to 150 femtoliter, it will be considered as WBC. And one which is around 40 femtoliter will be counted as WBC. So what does it mean? Your Coulter counter reads your RBC, WBC platelets mainly based on the size of the particle. Okay, right. This is with respect to older Coulter counters. Okay, because we have first generation Coulter counter, second generation, third generation. Your first generation Coulter counter will find out your RBC, WBC platelets based only on the size of the particles. Okay, but remember, your newer Coulter counters employ not only the size of the cells, but it also employs other principles such as flow cytometry, immunofluorescence, etc. Because we have some issues with respect to older Coulter counter method, which mainly detects the particles based on the size. But I repeat, newer Coulter counter methods also employs some other techniques so that some false issues with respect to older Coulter counter can be reduced. Okay? Right. So what is this? Look at this. Right. This is how a report will be given by the automated hemogram. So look at this. This is your WBC, number of cells per cubic millimeter. Here the count is 7,900 cells per cubic millimeter. RBC very very low. It is just 1.5 million. Your hemoglobin is 6. Your hematocrit, MCV. So many things are there. So with respect to RBC count, you have RBC number, your hemoglobin, your mean corpuscular volume, your mean corpuscular hemoglobin concentration, everything. So with respect to WBC, it will give you how many lymphocytes are there, how many neutrophils are there. So based on the WBC count and based on the lymphocyte percentage or neutrophil percentage, you will calculate the absolute neutrophil count or lymphocyte count. So for example, look at this. Here the neutrophil lymphocyte count is, let me say, 90%. So 90 divided by 100 into how many total, what is the total count? 7,900. So what is this? So look at this. 9 nines are 81, 8 9 sevens are 63. Along with that plus 8 comes around somewhere around how much it is? 90 into, let me say, 80, something around almost 7,600 or 7,300. So this is called absolute lymphocyte count because the lymphocyte percentage is 90%. So out of that 7,900 cells, 90% is contributed by lymphocyte. So absolute lymphocyte comes around somewhere between 7,300 cells. So the remaining 10%, 10 by 100 into 7,900. So let me say 8,000. So only 800 absolute neutrophil count. So in this way, based on the percentage given by the automated hemogram and based on the WBC count, we will arrive your absolute neutrophil count and absolute lymphocyte count. Okay, right. And then with respect to platelet, here look at this platelet 1.2 lakh. And apart from that, there are some other things like your MCV, mean corpuscular volume, or reticulocyte count. For platelet, you can have mean platelet volume and then PLCR, that is platelet ratio. What is reticulocyte count means? The same is for the platelet. Reticulocyte count high means that your bone marrow is working well. In the same way, platelet ratio is high means your bone marrow is working well. So you can have a WBC count, a differential count, the RBC parameters, WBC parameters, platelet parameters. So many things you can derive from a simple automated hemogram. Right. So let's come to that. So what does it mean? An automated hemogram literally replaces your newborn chamber nowadays. It is a point of care test. So let me say, what are all the different types of Coulter counter? 1. The basic Coulter counter in any lab wherever you go in the world is a three-part counter. What do you mean by a three-part counter? It is mainly based on the number of what are all the how many WBC parameters are there. You know that WBC parameters are 5 in number. One is neutrophil, second is lymphocyte, third is eosinophil, fourth one is basophil, fifth one is monocyte. So there are 5 types of WBCs are there. But in a three-part counter, you will get only three things, two things. One is it will read your neutrophil, it will read your lymphocyte. The remaining things will be given as printed as mixed. This mixed contain basophil, eosinophil, and monocyte. So what is the drawback with respect to this three-part counter? It will measure only neutrophil, it will measure only lymphocyte, it will not measure your basophil, eosinophil or monocyte. Okay? That is the drawback of the three-part counter. Three-part counter means it is mainly based on differential count of WBC. Only neutrophil, lymphocyte and mixed. Mixed include rest of the things that is missed in three-part counter. So then what is a five-part counter? Very simple. Look at this. A five-part counter apart from neutrophil and lymphocyte, instead of giving the result as mixed, it will give you what is the lymphocyte, what is the eosinophil, what is the monocyte, and what is the basophil. So five-part counter gives you all 5 parameters of your WBC. Now we have right now we are moving further ahead. Our automated hemogram is going ahead of times. So what does it mean? Apart from your neutrophil, lymphocyte, basophil, your 7-part counter will show you nucleated RBCs, and apart from that immature granulocytes, and some other advanced Coulter counter will give you how many immature platelet and what is the exact reticulocyte count. So what does it mean? It gets upgraded each and every year. As a result of which, it becomes sophisticated enough to identify the exact problem with respect to hematology without using a peripheral smear. I repeat, the gold standard is peripheral smear study. I am not talking about your newborn chamber. It is totally gone. I'm talking about your peripheral smear study. What is a peripheral smear study? Take a drop of blood, just make a smear and look into the eyes and find out. But it is time consuming process. Okay. But in the course of time, your peripheral smear study, even though is gold standard, is replaced by this advanced automated hemogram methods. Okay. So 7 point, even we have 10 part, 11 part, so many things are coming on. The more and more the sophistication is, the less and less the requirement of a peripheral smear study, the less and less requirement of your human machine. Humans are literally replaced by machines. But still, if you have some confusions, you need to go for a smear study. Okay? Right. But right now, the point of care means suddenly, as early as the patient comes in, I want a diagnosis. For that, you need to go for a Coulter counter. 3-part, 5-part, 7-part. The basic thing that but each and every lab should have is a 3-part counter. Okay? 3-part counter will give you, what are all the things it will give you? Lymphocyte, neutrophils, mixer. That's all. Right. So look at this. Very, very simple. Look at this. So this is the lymphocyte graph. So what is this? This is called histogram. What is this? This is called histogram. Your Coulter counter will give you the number in percentile, as well as it will give you this type of histograms. What do you mean by this histogram? Look at this, 0 to 100 femtoliters. So or else I can say what is the center point? Median. Median is 50 femtoliter. Whenever a cell is 50 femtoliter, it will be counted as lymphocytes. And you can compare this is, so x-axis is mainly meant for size of the RBCs, and this y-axis is mainly meant for percentage of cells. Okay, so you can have, so always a standard deviation. This side mean you have a mean, so this is the mean is 50 femtoliter. This side how much? 2 standard deviation, minus 2 plus 2 standard deviation. But on an average, a cell which is of 50 femtoliter in size will be counted as a lymphocyte. Okay, now look at this. Now you have mixed. Mixed means you have monocyte, basophil, lymphocyte, eosinophil. All will be around 100 to 150 femtoliter. But look at this. The amount of monocyte, basophil, lymphocyte. Look at the height of the peak. The height of the peak is less. That means what? That means what? Your absolute monocyte count, basophil count, eosinophil count will be less than somewhat 10% together. Whereas your neutrophils around 40%, your lymphocyte around 60%, the remaining 5 to 6 percentage will be covered by this monocyte, eosinophil and basophil. Okay? And then neutrophil. What is the average size of your neutrophil? Look at this, average size of your neutrophil around 200 femtoliter. So any cell which is 200 femtoliter will be counted as neutrophils. And look at this, the peak of lymphocyte is high. So what does it mean? In the total count, you have a differential count. Differential count means how many percentage of that particular cell is contributed. So I repeat, PG, we will usually our PGs used to write N, L, M. N means neutrophil percentage, somewhere around 40%. 40%, I repeat, L means lymphocyte, somewhere around 55 percentage, and finally mixed somewhere around 5 percentage. That means lymphocyte contribution is much, your neutrophil contribution by second, the less number of contribution in case of total count by other monocyte, eosinophil and basophil. So this is how the histogram has to be interpreted. It doesn't mean that not only you need to look for the total number of cells to look for ANC, ALC or AEC. By simply looking into this histogram, a diagnosis of absolute lymphocytosis, a diagnosis of absolute neutrophil, eosinophil, everything can be made. Right? So in the course of time, tomorrow I will be taking all those things. So look at this, very, very, very easy. Look at this. So I repeat, first peak lymphocyte, second small peak is by monocyte, basophil, eosinophil, and the third peak is by neutrophil. But look at this first figure. The second peak is not that much. The third peak is not that much. Predominantly you have only lymphocyte. So what does it mean? This is a case of absolute lymphocytosis, very high lymphocyte count. There are so many causes. It can be an acute lymphatic leukemia, it can be a pertussis, it can be an infectious mononucleosis. By simply looking into the peak histogram, you will find out whether it is a lymphocyte, neutrophilia or monocytosis, and based on that the etiology can be thought of. Look at this second one. So the first peak is not that much, whereas the second peak is too much. This second peak can be due to monocyte, basophil or eosinophil. Whenever you have monocytosis, whenever you have a basophil, always think in terms of chronic myeloid leukemias or juvenile myeloid leukemias in pediatrics. I am not talking about adult etiologies. I am talking in terms of pediatric etiology. Presence of basophils, presence of monocytes, easily visible basophil, easily visible monocytes, unless otherwise in pediatric indicates myeloproliferative disorders. And finally, look at the hemogram. The first peak lymphocyte is very small, maybe 5%. Second peak, very, very small, maybe around, this is around 5%, this is around 2%, this is around 97%. What does it mean? Absolute neutrophilia. Absolute neutrophilia. Probably a bacterial infection, or else I can say the child has been suffering from sepsis. But so what does it mean? By simply looking into the graph of the histogram and by finding out where the peak it is, you are going to find out the probable etiology without doing any confirmatory test, because your treatment is mainly based on point of care test. Sometimes you will not have a technician, or else you will take some time for the blood culture to grow. You need some pathologist to come and see whether it is a malignancy or not. But before their arrival, just based on one drop of blood, you can plan your management before they come. That is the importance of point of care of test by your automated hemogram. I hope you understood the fact behind this automated hemogram, right? Now, so this is with respect to lymphocyte. This is with respect to the total count, particularly your lymphocyte, particularly your WBC parameters. Now, RBC parameter, the same. So RBC parameters, mainly what are all the things you are going to have? With respect to RBC, you can have an MCV, you can have some MCH, you can have red cell distribution width. It will show how much is the hemoglobin, and hemoglobin into 3 will be your hematocrit. These are all the parameters that will be shown by your automated hemogram. With respect to platelets, it will show what is the platelet number, it will show what is the mean platelet volume, as well as it will show platelet ratio. That means it is equivalent of the reticulocyte count for an RBC. Platelet ratio is the one which is for platelets, which indicates that the bone marrow is actively working. Nothing is destroying your marrow. So there is a peripheral destruction. Right. For all practical purposes. I repeat, for all practical, this is very, very important. For all practical purposes in pediatrics, the normal total count is 5,000 to 1,500. When the total count is less than 5,000, you will call it as leukopenia. When the total count is more than 15,000, you will call it as leukocytosis. And in that, if the absolute neutrophil count is more than 10,000, you will call it as neutrophilia. And when your lymphocyte count is more than 8,000, you will call it as absolute lymphocytosis. For children, but for an adolescent between 10 to 19, a count of more than 4,000 should be called as lymphocytosis. What does it mean? So over a period of time, your lymphocytes will be replaced by neutrophils. Right? So this is very, very important when you apply this automated hemogram whenever any patient complains with some diseases. So please remember, it is not that difficult to remember. In the course of time, in our subsequent session, you will come to identify all those things. So this is with respect to WBC parameter. Then what about this platelets? Look at this RB, platelet of less than, even though a platelet of less than 1.5 lakh is called as thrombocytopenia, but for practical purposes, a platelet count of less than 1 lakh should be given importance, right? Anemia means, even though the definition says less than 11, less than 11.5, less than 12, based on the age. So 6 months to 6 years, 6 years to 11 years, more than 11 years. So you have that kind of WHO definition for anemia. But for practical purposes, a hemoglobin of less than 10 gram per deciliter should be called as anemia. Anemia. So a small revision. What is the revision? What is the small revision that we need to have? Let me ask you again. So total count is between 5,000 to 15,000. What is mean by leukopenia? A leukopenia means less than 5,000. What is leukocytosis? It is more than 15,000. What is mean by increased absolute neutrophil count? More than 10,000 per cubic millimeter. What do you mean by absolute lymphocytosis? For children, more than 8,000. For adolescent, more than 4,000. What do you mean by anemia? A hemoglobin of less than 10 gram. What do you mean by thrombocytopenia? A platelet of less than 1 lakh. Okay? Right. Right. So with respect to RBC parameters. So with respect to RBC parameters, please concentrate on this MCV because anemia is mainly classified based on this MCV, whether it is microcytic, normocytic, or macrocytic. Okay, so how do you roughly calculate this MCV for that particular age? Remember, normal, the rule of thumb is 70 femtoliter. If it is less than 70 femtoliter, you will call it as microcytic. If it is more than 95 femtoliter, it will call as macrocytic. But you want an exact MCV, very, very simple. Lower limit is 70 plus age in years. For example, let me say I am seeing a MCV of a 5-year-old boy. So what is the lower limit? The lower limit will be 70 plus 5. So 75 femtoliter. What which should be is high now. What is its higher limit? Higher limit is, look at this, 84 plus age. Age means 5 into 0.6 into 0.6. So 5 into 0.6, 30. So 3.0. So 84 plus 3. What is the value? 87. So for a 5-year-old boy, an MCV of less than 75 is called as microcytic, and an MCV of more than 87 is called as macrocytic. That's it. Is it tough? No, not at all. Then look into this. I am not going to give any importance to MCH. Instead, I want to give an importance to MCHC. So remember, mean corpuscular hemoglobin concentration per gram of blood. What is the hemoglobin concentration in per liter or deciliter of RBC? That is called mean corpuscular hemoglobin concentration. Let me say the normal value is 32 plus or minus 2. Let me say it should be a maximum of 34. And remember, when it touches 32, that means then the amount of hemoglobin in that particular RBC is very, very high. So what does it mean? Whenever your MCHC is high, the RBC cell is reduced. In which condition you will lose your RBC membrane? Hereditary spherocytosis. So instead of looking into the peripheral smear for loss of central pallor, which is pathognomonic of spherocyte, just look into the MCHC. MCHC more than 38 unless otherwise proved is hereditary spherocytosis. Right. What do you mean by red cell distribution width? Very simple. It is nothing but anisocytosis. What is mean by anisocytosis? Different in sizes of RBCs. So some cells are small in number, some cells are little bit more than that, some cells are variable in size. So your RDW is nothing but anisocytosis. Anisocytosis means variation in the size of the RBCs. So more the variation of the size of the RBC means more the red cell distribution width. A normal red cell distribution width for general practice, let me say 15. So more than 15 means red cell distribution width is high. Less than 15 means red cell distribution width is low. More the red cell distribution width means more number of different in sizes of RBCs. That usually occurs in nutritional anemia due to iron deficiency, folate deficiency, and B12 deficiency. And finally, reticulocyte count. Remember, when you have an active brisk reticulocytosis, it means that your bone marrow is active. You are not going to think in terms of a bone marrow infiltration or bone marrow hypoplasia. Instead, you need to think in terms of a peripheral destruction. So a high reticulocyte count always indicates that your bone marrow is functioning well. Right. Okay. Right, what else? So with this, a basic introduction of an automated hemogram is over. So tomorrow, kindly revise this and come. We are going to apply true automated hemograms, and you are going to find out the diagnosis based on this today's discussion.